Our next speaker will be Dr. Alaa Abdelgalil, is a distinguished consultant radiologist at Head and Neck Imaging, lead at Rakemore Hospital, NH Highland, with over 20 years of experience. He specializes in diagnostic and interventional head and neck radiology. A prolific author, international speaker, Dr. Abdelgalil is known for his innovative teaching style, using custom and graphics animation to simplify complex concepts. His dedication to advancing medical knowledge has made him a respected leader in the field. Welcome, Dr. Alaa.
Good morning, everyone. Thank you so much for joining us today. I'm really honored to take part in this conference here in Kuwait. I'm sure it will definitely be a great opportunity to share some insights with you. So my first topic today is going to be about imaging of tinnitus. So let's start with the definition first. So what do we mean by tinnitus here? So tinnitus is perception of relentless internal noise or ringing in the ears. And it's actually not a disease on its own. It is a symptom of an underlying problem, and hopefully with our scans we can try and find what the problem is. It has two types, so we can have pulse-style tinnitus, which is synchronous with the patient's pulse, and it can be subjective or objective. On the other hand, we have the non-pulse style or the continuous tinnitus, which is unrelated to the pulse whatsoever, and it's almost always subjective, only heard by the patient. Very important to note that about 90% of the cases, these patients will have some degree of hearing loss on the same side. A few other important points that we need to know about. So non-pulse style tinnitus is way more common compared to pulse style tinnitus, about 90% versus 10%. On the other hand, positive scans, you're more likely to find positive findings in patients with pulsatile tinnitus, about 70% or so. And it's usually CT scans rather than MR. Only about 10% of the scans with patients with non-pulsatile tinnitus, you'll find a problem there, a positive finding there. So many causes actually are unidentifiable on your scans. For example, some medications can cause some continuous tinnitus, non-pulsatile tinnitus, like non-steroidals, diuretics, or tetracyclines. So now there's an important question that we get all the time from our ENT surgeons and our radiology registrars alike. What should we do for these patients, CT or MRI? And hopefully by the end of this lecture, I think you will be able to answer this question on my behalf. So generally speaking, CT is better than MRI if you're looking for a problem in the bones or the vessels. MRI, on the other hand, is better in spotting any problems in the brain parenchyma or in the vestibulocochlear nerve itself. Let's start with the first one, or the first main category, which is the non-pulsatile tinnitus. So we can divide causes of non-pulsatile tinnitus into three different reasons. The first one is abnormal vestibulocochlear nerve. The second issue can be a problem in the middle or inner ear. And lastly, we can have a problem in the brain parenchyma itself. Let's see some cases with abnormal vestibulocochlear nerve. I'll show you the classical appearance. I'm sure all of us have seen this before, which is the vestibular schwannoma. So classically on this fiesta or cyst sequence or the space sequence, you'll see a filling defect or a big mass lesion in the cerebral-pontine angle or the IAC. It usually enters into the canal itself, widening the porus acousticus, and this one is extending slightly into the medial aspect of the IAC. So this is the schwannoma, vestibular schwannoma. So it can be solid or cystic, and sometimes can be partly solid and partly cystic as well. So this is quite a big schwannoma. It's easy diagnosis to make on MR, right? Anyone can spot that. Let's see the same patient's CT and see if we can spot the problem. Despite the fact that this patient has a mass as big as a golf ball, you can actually easily miss it. We see that all the time, actually. So generally speaking, if you're looking for a vestibular schwannoma, MRI would help you a lot more than a CT. This is talking about big masses. So what about smaller ones? Which is actually we see very often as well. This is a patient with left continuous tinnitus, and on your sequence here, you can see a small filling defect, which you can appreciate if you compare both sides. In the basal turn of the cochlea on the left-hand side, the symptomatic side, there's a filling defect here. Give contrast and it's enhancing. So this confirms your suspicion that it is going to be a vestibular schwannoma. So CT, any chance you can see a problem here? This is the CT of the same patient. Nothing to see. So vestibular schwannomas, usually we'll spot them a lot easier on MR. It's very important to note that not every CPA or IAC lesion is going to be a vestibular schwannoma. There are other masses as well in the canal or the CPA. This is a patient with right-sided continuous tinnitus and hearing loss. And this is a small filling defect in the fundus of the IAC. And I'll show you this image. So this is the post-GAD sequence. And I'm putting this slide here for a very good reason. Don't fall into this trap and call this lesion enhancing. Because if you look carefully at the pre-GAD, you'll find that this lesion is inherently high on T1 signal intensity. So this is, again, a very common mistake that we see enhancing masked lesion, and when you go back to the pre-contrast, you'll find that it's actually high. If it is a lipoma like this case, that's fine. It's not a big idea. But if it is something like melanoma, this will cost the patient probably their life. Okay, so we need to spot them straight away. How can we differentiate between something like this, a lipoma, or a metastatic melanoma? Just a fat-SAT sequence, pre and post-contrast. You will find if it is suppressing completely, this is a lipoma. If it is not, this is a melanoma. I'll show you a case of melanoma here, another filling defect, right continuous tinnitus. And here, this lesion is, classically, you can easily say that this is a vestibular schwannoma, right? But look at the post-GAD first. Again, you can say that this is a post-contrast sequence of an enhancing schwannoma, right? This is the post-contrast fat-SAT. That's the pre-contrast fat-SAT here. So what is it? Still can be hemorrhagic schwannoma, but these are exceedingly rare. What's more common is actually metastatic melanoma. These are common tumors in the UK. I'm not sure whether or not they are common here. But see how important it is to go back to the pre-contrast, because you may overcall or undercall the true pathology. The next cause of non-pulsatile tinnitus is an abnormality in the brain parenchyma itself. And again, let's try and find out if CT would help you better or MR in each of these cases. So this is the patient with right continuous tinnitus. And here on the CT, you can easily spot the problem that we have a CPA lesion, which is cystic, extraaxial. But the CT didn't tell you exactly what it is. It could be something like an arachnoid cyst or an epidermoid cyst. MR can give you the diagnosis straight away, because the signal is not following that signal of the CSF, which means that it's not going to be an arachnoid cyst, it's something else. You need one more sequence to confirm what it is, which is your DWI sequence. So it's a restricting on diffusion. Nothing apart from an epidermoid can do that. So extraaxial lesion, restricting on DWI, of course, on all your sequences, it will not be following the CSF signal, so this is an epidermoid. So MRI, a lot better, so you don't need to do CT for these patients at all. It's just MR will make the diagnosis. Another patient with left continuous tinnitus. Can you see anything wrong here? Even on hindsight, I'll just show you the MR of this patient. You can spot easily the mass here. So this is the glioblastoma of the brainstem, but even if you go back to the CT, I think you will be overcalling a lot of normal patients as a GBM if you do that. So just take-home message here, most of the cases so far, patients with non-pulsatile tinnitus, MR is the best modality to start with. Another patient with bilateral continuous tinnitus. So what's wrong here? We have demyelination plaques throughout the brain, not just in the brainstem posterior where you'd expect the vestibulocochlear nerve nuclei to be, but it's throughout the brain as well. Again, very easy to diagnose on MR, but CT, you can say it's non-specific, right? Like small vessel disease, even post-radiotherapy leukoencephalopathy can be the same appearance. But on MR, it will give you a lot more confidence to call it that this is definitely MS. The patient will need a neurology referral. The last cause of non-pulsatile tinnitus is an abnormal middle or inner ears. And this patient has right-sided continuous tinnitus. Let's compare the porous acousticus on both sides. So the right-hand side is a lot tighter than the left-hand side, right? So normally the porous acousticus and the whole IAC needs to be in between 4 and 8 millimeters, not very tight, not very big, not patulous. The symptomatic side, it's very, very tight, which means that the nerves in between will be squeezed, and these are, of course, we know these nerves 7 and 8. 7 is a very resilient nerve, so it needs a lot of issues to cause facial nerve palsy here. Usually these patients will present with problems in the vestibulocochlear nerves first, and this is what we see in patients with idiopathic hyperostosis. However, so we don't know why this happens. However, Don't call it idiopathic until you see the patient again. You need to scan them with CT to make sure that actually there is no problems in the bone texture. And I'll show you the CT of this patient, because something like fibrous dysplasia can cause that as well. You can easily miss it on MR, but CT will give you more confidence to call it fibrous dysplasia or intraosseous meningioma. Metastases from breast cancer or prostate cancer can, again, can be the same appearance on MRI, but CT, it will tell you whether or not the texture is normal or abnormal. Another patient with left-sided ear pressure, continuous tinnitus, and conductive hearing loss with a bulging tympanic membrane. CT was able to tell you that we have a problem, which is opacification in the mastoid air cells and the middle ear cavity, but it didn't tell you exactly what it is. It can be a cholesteatoma, it can be something like otitis media, but it can be blood as well, right? MRI, this is the T1 pre-contrast. What does it tell us here? This is blood, which tells you that this is a case of cholesteatoma. So, in summary, non-pulsatile tinnitus, MRI definitely wins the race. Let's now move on to the next topic, which is the pulsatile tinnitus. And again, generally speaking, we have 4 different reasons for pulsatile tinnitus. These can be abnormalities in the vessels, abnormal bones transmitting pulsations more than they should, bony dehiscence between the canals and the bones, or the middle ear, and lastly, highly vascular tumor, either in the middle ear cavity itself or anywhere around the petrous bone. Let's start with the first one, which is dehiscence in the bones. We have a few vulnerable areas which we need to know about. You need to prepare a checklist to check these areas to make sure that you're not missing a thing. The first vulnerable spot is your jugular bulb. If we have an abnormal dehiscent jugular bulb, what's going to happen? The patient will hear their own pulsations in the jugular bulb through the defect through the hypotympanum into the tympanic cavity. So we need to know how a normal jugular bulb looks like first. The bone in between the jugular bulb and the hypotympanum needs to be very well formed on your coronal sequence, and as Yusra told us earlier on, that you need to make sure that the roof of your jugular bulb is way below the level of the inferior IAC, as you can see here. Let's see a few examples. Patient with left-sided pulsatile tinnitus. So here it's a very easy diagnosis to make on your CT that we have an exposed jugular bulb on the left-hand side. There's a dehiscence in the floor of the tympanic cavity. So this means that the patient can hear their own pulsations through the dehiscence. Classically, these patients will present with an intact tympanic membrane. There's no perforation there, behind which we have bluish discoloration. This is an easy diagnosis to make on CT. Let's show you the MR of the same patient then. That's the MR. Can you spot the dehiscence here? There's no chance. Maybe contrast will help? Can anyone see the dehiscence here? No. Why? Because MRI will not be able to tell you whether the signal void you can see is actually the bone or the gas. So that's why in any dehiscence, generally speaking, MRI, forget about it. Even with GAD, that won't really help. CT will give you the answer. The other vulnerable spot, the next one, is dehiscence in the sigmoid plate. So this is the plate of bone in between the mastoid air cells and the sigmoid sinus. And if we have a dehiscence here, what's going to happen? The patient again will hear pulsations from their own sigmoid sinus through the defect into the mastoid air cells, and from there to the middle ear cavity or the inner ear structures. And let's start with knowing how a normal sigmoid plate looks like. It should be well formed all around, as in this case, so both sides should be completely intact. Now, this is a patient with left pulsatile tinnitus, and what's wrong here? So we have a defect in the sigmoid plate on the left-hand side. The patient can hear the pulsations from the sigmoid sinus directly into the mastoid air cells. MRI, will it help here? No chance. The next vulnerable spot is carotid dehiscence. So carotids can be dehiscent in 2 different areas, either directly with the middle ear cavity or the petrous apex, and the second site is between the carotid and the cochlea itself, which we call carotid cochlear dehiscence. And this actually can happen with either the apical turn or the basal turn of the cochlea. And it's a very tricky diagnosis to make, so you need to be very, I would say, paranoid to spot it. That's why you needed to prepare a checklist, all of these dehiscences. So how does a normal carotid canal look like? It should be well-formed all around. There's no defects there whatsoever. So this is a patient with left pulsatile tinnitus. What's wrong here? So we have a big defect on the left-hand side, the symptomatic side. The patient can hear their own carotid pulsations in their ear. Patient with left pulsatile tinnitus, and you can see the carotid canals on the right side is fine, but what's wrong with the left? Can you see this small defect there? Let's just zoom in. Can you see that? It's a tiny defect. So this is a carotid cochlear dehiscence. It's a very subtle thing, so we need to look at this area. Next vulnerable spot is dehiscence in the bony labyrinth, and as Suresh has just mentioned, the most common area is the superior semicircular canal. But usually they don't cause pulsatile tinnitus, so you need something else so that the patient can present with this kind of symptoms. So these patients usually present with ear pressure or what we call Tolio phenomena. But if we have, at the site of the dehiscence, a very small vessel next to us, this means the patient in these cases can actually hear their own pulsations, which is not common, as we said. How does a normal superior semicircular canal look like? It should be well-formed. The roof should be all around intact, no defects whatsoever. This is a patient with right pulsatile tinnitus, so what's wrong here? We have a small defect in the roof. But again, why is the patient presenting with pulsatile tinnitus rather than just Tolio phenomena or ear pressure? Because if you look on the axials here, where is this defect? What is this vascular structure here? This is the superior petrosal sinus. That's why the patient can hear the venous pulsation through the defect. The next cause of pulsatile tinnitus is an abnormality in the vessels themselves. This is a very important point to note, please. So any neurovascular conflict or a vascular loop touching the cranial nerve number 8 is unlikely to be the cause of pulsatile tinnitus. Try and forget about this. Look for something else. You may be able to find something else. Okay? So neurovascular conflict can happen in other cranial nerves, like, for example, trigeminal is the most common. We have hemifacial spasm with cranial nerve number 7. But for cranial nerve number 8, it's not fully documented. We can't really say that this is the cause of the pulsatile tinnitus. Look for something else. However, vascular loops can cause issues other than neurovascular conflict, like this example for here, patient with left pulsatile tinnitus. So this patient on CT is very good. We'll give you the diagnosis straight away. This is a post-contrast CD axial view. And we can see that there's actually a vessel digging a hole behind the pores acousticus. So the patient actually can hear the pulsations from the vessel through the bone into the middle ear and inner ear structures. And this loop is actually an anterior inferior cerebellar artery causing this issue. So but again, vascular loop touching or displacing number 8, cranial nerve number 8 is not going to be your suspect. Look for something else. Another patient with bilateral pulsatile tinnitus, this is very obvious. You can spot that on CT or MRI alike. So it's not, CT, of course CT is the easier for us, but MRI again can make a diagnosis easily here with patient with extensive cerebellar AV fistulas. Patient with sudden onset left-sided pulsatile tinnitus, left neck pain. So this was a young patient. So what's wrong here? There's abnormal flow in the left carotid in the petrous segment, right? And these patients usually present acutely with something like a stroke, TIA symptoms, and sometimes with Horner syndrome because you need to check down there in the neck and we have a dissection. So this is the flame sign that we see in dissections, and these patients can also, in addition to the TIA or a stroke presentation, they can present with acute pulsatile tinnitus as well. Next cause for pulsatile tinnitus is highly vascular tumor, and this is, of course, the classic one that we all know about, a small tumor sitting on the cochlear promontory, which typically on otoscopy, it will be a flesh red-colored lesion behind an intact tympanic membrane. It's a very easy diagnosis to make, but you need to check that the hypotympanum is intact so that it's not a jugulotympanicum glomus tumor. Once you see one of these in any part of your head and neck, you need to check that there's no other lesions as well, because this may be associated with a hereditary syndrome, which is called hereditary paragangliomatosis. So if you see one, look for more. CT, it's an easy diagnosis, right? Let's see the MR of the same patient. This is the Fiesta sequence, which we routinely do for patients with hearing loss or tinnitus. Can you see the glomus? No chance, right? Only contrast can help you here. But even with contrast, you need to be very, very thorough. You need to check everything to spot it, because usually the glomus is very, very small, right? Okay. So again, CT wins the race here. Patient with, another patient with left pulsatile tinnitus. So what's wrong here? We have erosions in the lateral aspect of the symptomatic side. So this is the jugular foramen. This is the typical appearance where a glomus jugulare starts laterally. And on the post-contrast, again, you can see the mass itself displacing the jugular bulb slightly medially. Okay, CT, it's an easy diagnosis to make. MRI, of course, you'll spot it, but you need GAD. If you just rely on your Fiesta or sequence, you will definitely miss it. And as we agreed, if you see a glomus, you should do what? Look for more. Any other lesions here? There you go. Okay, so there are 4 sites that you need to check in patients with glomus. So glomus tympanicum, glomus jugulare, glomus vigali, and also carotid body tumors. Both sides, don't forget. Patient with right-sided pulsatile tinnitus and feeling pressure in the right ear. Again, on CT, this is an easy diagnosis, relatively easy diagnosis to make. So what's wrong here? We have bony expansion, we have sunburst appearance of preosteal reaction, and this lesion is extending into the mastoid air cells and the tympanic cavity. So it's a pretty obvious case of intraosseous or intraosseous meningioma or meningioma en plaque, right? But of course, a patient like this, you can make the diagnosis on CT, especially if you're giving contrast, but you need to recall them to see the exact extent of the tumor. And here you can see how elegantly MRI is showing you the problem. So we have a big enhancing mass lesion extraaxial with the dual rotate. So these are all classical findings of a meningioma which can present or cause pulsatile tinnitus. Patient with right-sided pulsatile tinnitus and right facial nerve palsy. So what is wrong here? So we have, this is your labyrinthine segment, and this is the tympanic segment of your facial nerve. Okay, but where the geniculate ganglion is, we can see a lesion which we call honeycomb appearance lesion in the geniculate ganglion. So these are classical findings of what kind of tumors? Hemangiomas. So we used to call them hemangiomas in the past, but nowadays we call them venous malformations. Again, CT is an easy diagnosis to make, but of course, a patient like this, you need to recall for MR because you will never appreciate the enhancement on the post-contrast scan with CT. So you need to recall them for an MR. Patient with right otalgia, hearing loss, and pulsatile tinnitus. So what's wrong here? Again, easy diagnosis to make on CT. We have a destructive lesion in the middle cranial fossa. The most common lesions in the middle cranial fossa are myeloma, which is a plasmacytoma, of course, metastases, and lymphoma. So we know where the problem is on CT, but of course a patient like this needs to come back for an MR, and the MR did show you a destructive lesion in the pituitary apex going into the clivus, just below the pituitary fossa as well. So if you give contrast, it's intensely enhancing. So this was a case of plasmacytoma, one of the common middle cranial fossa lesions. Now, the last cause of pulsatile tinnitus is abnormal bones. Patient with right-sided mixed hearing loss and pulsatile tinnitus on the same side. So what's wrong here? Did anyone spot the problem? Fistula antifenestrum, here. So we have lucencies. It should be as dense as the rest of the pituitary bone, right? Will you be able to see anything on your MRI Fiesta sequence here? No way, right? So MRI will not help you in these cases of fenestral otospongiosis. So later on, the otospongiosis can spread and cause retrofenestral, which is the cochlear otospongiosis. And of course, in these cases, MRI will be able to help you. But let's see an example here. Patient with bilateral, but asymmetrical conductive hearing loss, pulsatile tinnitus worse on the right side. So MR did show you the...
2 minutes, please.
Almost done. So MRI did show you the problem here on the right side, but can you see any problem on the left side? No. Even in retrospect, you can't spot the retrofenestral otospongiosis here. So CT was better in detecting that. I think this is the last case. So patient with bilateral pulsatile tinnitus, and this is an easy diagnosis to make again on CT. MRI can be very confusing. So there's bony expansion with cotton wool appearance, and this is what we see in Patchen's disease because of the hypervascular nature of the bones. These patients can present actually with pulsatile tinnitus. So it's very obvious that pulsatile tinnitus patients in the race, CT is the best imaging modality to start with. So let's go back to the very first question. CT or MRI? Let's not just think about these modalities as if they are competing with each other. They're rather actually completing each other. So in many occasions, patient with an equivocal finding on CT, you will need to recall for an MR. Patient with possible finding on MR, you will need to recall again for a CT. By this, I'd like to finish, and thank you for your attention.